Hi everyone. I am currently on my DR rotation, but one of the residents I worked with is IR, and he just encouraged me today to watch like a Y90 embolization for hepatocellular carcinoma or HCC. So I just kind of wanted to make a PowerPoint and talk about it. So what is TARE? TARE is transarterial radioembolization. Um, It's a type of brachytherapy. What are the goals of brachytherapy? Basically, to reduce the amount of radiation to healthy tissues and really just target the tumor. So the overall goal is local radiation close to the tumor site and delivering high doses of radiation therapy. The embolization part is inserting these beads or injecting them and blocking the end arterioles and interrupting local blood flow, which then kills the tumor. So you can see the beads going here. This is like the local blood flow, and it's kind of going to disrupt all of that by delivering radiation, and the tumor is going to shrink. Indications, this is really good for HCC because it has a high reliance on the hepatic artery. And you can see that here. So it really is just target therapy. Y90 stands for yttrium 90. It decays to zirconium 90. It's a pure beta emitter. The half-life is about 2.67 days. This is like the penetration 2.5 millimeters by a maximum of 11. And then there's two forms, and I kind of put, this is the one that we use today. So there's glass microspheres, and the company is called TerraSphere. These are the ones that are indicated just by the company for the treatment of HCC. And then there's resin microspheres, by also called like sear spheres. And these are here, and these are used for treatment of metastatic colorectal cancer to the liver, so liver mets from colorectal cancer. So this is just talking about the TerraSphere. Again, these are like the glass microspheres. The diameter of these spheres are 20 to 30 micrometers. The activity is about 25. And then dosing, recommended dosing is like 80 to 150 grays of radiation. This is really limited on, or depending on, the amount of radiation that reaches the lung. So lung dosing, overall hepatic function, and then what the liver mass looks like and its characteristics on CT MRI. This is just to say that people with cirrhosis, if you have a cirrhotic liver, it might get less a dose of radiation, more like 80 to 100 grays. And then dosing for radiation is really limited by the delivery or shunting to the lungs. So the limitations are set at 30 grays per infusion to the lungs and 50 gray cumulative dose to the lungs. What are the indications for Y90? So right now, the really strong indication is unresectable HCC. This is with or without portal vein thrombosis. And Y90 can also be used as like a bridge to liver transplant. We'll talk about that a little later. In the works, you have, as we already mentioned, like metastatic colorectal cancer, especially with liver mets, liver dominant mets from the breast, prostate, melanoma, some sarcomas. It's been used in intrahepatic cholangiocarcinoma. There's been better outcomes with neuroendocrine, breast, prostate, and ovarian cancers, and less favorable outcomes with lung, gastric, esophageal, and pancreatic metastases. What are the contraindications? So absolute contraindications, which just means that we're not going to do this at all, are life-threatening extra hepatic disease. For example, if you have encephalopathy, which a lot of patients with cirrhosis, for example, do have. If you have uncorrectable flow to the GI tract, that's no-go. And then contraindications to angiography in general. So if you have uncorrectable coagulopathy, renal insufficiency, iodine contrast allergy, severe peripheral arterial disease that prevents arterial access, that would be a limiting factor. And then hepatopulmonary shunting. This can cause radiation pneumonitis, so we're going to avoid Y90. For relative contraindications, which is like a maybe we should, maybe we shouldn't, we already talked about like with or without portal vein thrombosis. So it is a relative indication if there is a complete main stem occlusion, or if there's a main stem portal vein thrombosis in the setting of a poor Child-Pugh score B or C. Other relative contraindications, we have biliary obstruction, for example, compromise of the sphincter vodi, poor functional status, which is pretty much a relative contraindication in all of cancer therapies anywhere, and then pulmonary insufficiency and poor hepatic reserve seen with ascites or bilirubin of greater than 2. What does the pre-treatment workup look like? So, of course, we're going to get our labs. So, LFTs, liver function tests, albumin can be used to look at hydration, nutritional status, LDH, and of course, your tumor markers, CEA and AFP specifically for HCC. For imaging, we're going to get CT enhanced. Contrast enhanced, CT, MRI, ultrasound, and then chest CT to look for lung mets, bone scan, nuclear medicine bone scan to get and see if there's any bone metastasis, and then other imaging just to see if there's patency in the portal vein. For patient prep, so a lot of the times they're MPO for 8 hours before the procedure. You need peripheral IV access, and then some medications, hydration, antibiotics, Zofran, Benadryl, steroids. For anesthesia, patients need to be able to follow instructions, especially like breathe in, breathe out, don't move. So they're given some fentanyl for pain and midazolam or Versed. And yeah, this is kind of the pre-treatment mapping. So this is to identify variant anatomy. It's done 1 to 2 weeks before the procedure. Usually things that people look for are the cystic artery, the right gastric artery, the falciform artery, and then the gastroduodenal artery, because you kind of want to avoid causing GI bleeding and ulceration, as well as bile duct because of strictures. This slide is just talking about the Technician 99 macro aggregated albumin or 99 MTC MAA mapping. So this is basically like a pre-treatment mapping before the actual Y90 embolization. During this mapping, the MAA is injected intraarterially into the hepatic artery, and this would be at the site, at the intended site of where you want to administer like the microspheres for the Y90 procedure. And then basically you image using like a SPECT CT. And the reason why you do this is because the mapping allows you to predict the intrahepatic distribution of the Y90 microspheres. It quantifies like the lung shunt fraction to make sure that you're not over the risk or having a high risk of pulmonary radiation. And it also detects any like extrahepatic deposits that could lead to non-target radiation injury, for example, GI ulceration. This is a really complicated slide, but if anyone is interested, so Y90 setup, obtaining access is through this modified Slendinger technique, and access is mostly through the common femoral artery unless commonly through the radial artery. This just shows, this is not exactly it, but it just shows something for someone that's not using a catheter in any way, shape, or form. So first they place the needle into the artery, which is what's seen here. Then you insert the guide wire. Then you remove the needle and leave the guide wire. And then you use what's called like a micro puncture dilator that's placed over the guide wire. So it kind of looks like that. And then the inner part of this micropuncture dilator and the guide wire are removed, but this larger diameter wire is placed. And then after you place the larger diameter wire, you remove the micropuncture dilator. And then you place a 4 or 5, I don't know why this is fiber, 4 or 5 French sheath is placed over the larger wire to secure arterial access, and then you have a base catheter that's placed, that is advanced through the large diameter wire, and then the large wire can be removed so that the radiologist can take like angiograms. So all of that to say, this is probably more important. So you have a base catheter, which is at 4 or 5 French, and you see that here and here. And then this is to access the femoral, common femoral artery, and again we said less common, the radial artery. Then you have a microcatheter that's about 2.7, 2.8 French, that's coming out, and then you have a micro wire that's 0.014 or 0.018 inches, which is this. So the really important part is that the microcatheter and the micro wire are advanced to the target vessel, and then the micro wire is removed. This is also a very complicated and busy slide, but this is really important. So for the actual embolization part, you want to apply a brisk continuous forward flow of saline, like a saline flush, from a 20 milliliter syringe. If the flow is over 30 psi's, then excess fluid will drip into the overflow vial, which is over here. So it would go like this, and it's flowing through, and then there's excess, and it would go into this 20 milliliter overflow vial. So the radiologist or the IR resident or attending should first apply pressure to create overflow, because you want it to actually push through, but then slowly decrease to a pressure that's below 30 psi's. And this is to make sure that no microspheres are wasted. The full dose of the microspheres are usually administered and given in the first 5 milliliter injections, but you want to use at least 60 milliliter saline to get that all through. You basically give 3 flushes of 20 cc's, and then you do this until the dosimeter reads 0.0 milliliter per hour. That means that there's no residual dose of the microspheres and that it's all given to the patient. This is really important because the microspheres are transparent, so you can't see them. And my question was like, why is that? And so no contrast is used to actually see the beads, because the contrast makes them very sticky. And this is to avoid the beads actually getting stuck in the microcatheter and not delivering the whole dose. So then the microcatheter is pulled back and removed, and then nuclear medicine and the physicists are there at the same time that the IR team is there, and they dispose of all the radioactive material. This is again just showing the actual setup. So post-procedure management, so the patient's going to be rolled back to nuclear medicine for further imaging. They're going to look at and evaluate the liver and lung doses and maybe get a PET-CT. For outpatient management, they would be discharged the same day. And then post-op meds, usually patients are given a PPI to prevent gastritis or gastric ulcers. And then some patients, not all, are given antibiotics. Antibiotics are good for patients with a history of biliary interventions like biliary stents or biliary enteric anastomoses. Usually it's 10 days of fluoroquinolones to prevent abscess or radiation cholecystitis. And then clinic follow-up, you're going to follow up in clinic in 4 to 6 weeks with repeat labs and a repeat CT or MRI. And then recovery is usually 30 to 60 days after the last treatment. What are the complications of Y90? So one of them is this post-embolization syndrome where patients present with fatigue, nausea, fever, anorexia, weight loss, and abdominal pain. There's also something called idiosyncratic reaction where patients get shakes, chills, and alterations in vital signs. This occurs for about less than an hour after the procedure, and patients are kept for supportive care through hydration. And then you have things like hepatic dysfunction, radiation lobectomy, and I didn't finish my sentence here, but it's basically an increase in the ipsilateral lobe volume and kind of a decrease in the contralateral lobe volume. And then you have radiation-induced liver disease, or RILD. And you can see ascites, jaundice, hepatic failure. This is rare, but also potentially fatal. You can get lymphopenia, and then GI issues. For biliary, where you can get like biliomas, cholecystitis, cholangitis, and liver abscesses, and then gastritis. What about the efficacy? So for HCC, the response is 35 to 47%. Necrosis is usually takes 30 days. Tumor shrinkage, 120 days. Survival, when you compare with and without, so 15 to 24 months compared to 8 to 14 months. And then tumor progression has a longer time with Y90, so 7.9 months compared to 5.6. Advantages is that there's low toxicity and that it can all be done in a single session. Disadvantages is there's not great comparison, it's a high cost, and there's no consensus for optimal use. And then when compared to chemoembolization, Y90 has a longer time to tumor progression, like we said. It has similar improved response rates, comparable or better overall survival in selected patients. It's more favorable safety profile, less need for hospitalization, which is huge in cancer patients. And then even though chemoembolization is still the standard for intermediate stage HCC, there is a higher risk of that post-embolization syndrome and hospitalization. So Y90 is really used for patients that have a poor tolerance to chemoembolization, if they have larger tumors, and again, it's that bridge to transplantation, although there are some limitations to cost and logistics.